I'm joined today on the Bipartisan Brief by Dr. Ryan Willen, based out of Arizona, where we've unfortunately seen cases surging recently. And Dr. Willen, my first question is kind of an open-ended question. What are you seeing? Tell us what's actually going on in Arizona, but also with this disease.
Sure. So just a little background on kind of where I'm at, kind of what I'm seeing. I'm one of the residents at University of Arizona in Phoenix at Banner University. So we rotate through different rotations, part of internal medicine residency, which I'm a part of. So in the last 3 months, I did a month of ICU, so kind of caring for COVID and non-COVID patients who are critically ill. The month after that, so last month, I was with the COVID, kind of what we have as a COVID rotation for our hospital. So working hand in hand with the doctors and nurses to care for people who are kind of not quite as sick as needing the highest level of care, but still pretty sick patients who are COVID positive or suspected COVID positive. And then now this month I'm at the VA. At the VA, they actually have the residents not seeing the COVID patients. So I kind of have I see the flow and I kind of see the number of cases and stuff, but for the last 3 weeks, I haven't been working directly with the COVID patients and the COVID population. So kind of an interesting perspective, just seeing kind of the sickest of the sick, a little bit less sick, and then being on the other side, taking care of patients who don't have COVID who are coming into the hospital. So what I would say about the patients that we had in our COVID ICU is that compared to other viral pneumonias, which is what COVID-19 is, it's a virus and it's a really bad viral pneumonia. This is the worst of the viral pneumonias we've had. So it's worse than the respiratory symptoms you get with the flu. It's worse than, in terms of the number of people who are being infected and the amount of time that they're having to spend in the ICU. It's just not really comparable. So people they're more sick, their respiratory symptoms are more severe. And we kind of have been watching out for this inflammatory response that a lot of people are having, where you can get multi-system involvement, meaning it's not just the lungs. It might start with just the lungs, but you end up having heart components, you end up having kidney components, kidney failure, heart disease, arrhythmias. And it seems like there's an increase in hospital delirium in these patients too. So when they do need to get intubated, for people that have coronavirus, they end up on they end up on the ventilator for a long time, it seems. We also had a lot of people who would be extubated and then end up needing to be reintubated later. 3 months ago when I was in the ICU, most of the cases we were seeing were coming from the Navajo Nation. So they got hit pretty hard, and it was a lot of families. So it's kind of tough to watch. It would be, mom, dad, brother, sister coming down, some people young, some old, a lot of people with medical comorbidities that would end up in the ICU, but some people just, maybe young person, a little bit overweight, and they would end up critically ill. They'd end up intubated and kind of these prolonged hospital courses. So the time in the hospital, I think, is what was really unique about these coronavirus cases, that, rather than maybe 4 or 5 days, get over the pneumonia, get off the vent, go home, they're having these prolonged hospitalizations and they're very sick. It's different than the normal ICU in terms of our hospital doesn't allow any visitors. So all of the conversations that we would have, so the patients for the most part in the ICU, they're intubated, they're sedated. They can't really, we give them little sedation vacations, wake them up and stuff. But for the most part, all of the information we're relaying and, exchanging goes from our team to whoever the family member is that they elect as a representative. So it's a weird thing to not be able to talk to and see the patient's families. It's all over the phone and kind of creates a different dynamic. So that was a unique experience. Moving out and going into the COVID floor, kind of like the step down from the ICU, also a unique experience. For the most part, we tried to limit the number of people in and out of the rooms, try to conserve medical supplies, but we just have a really high suspicion with these people that they can go downhill quickly. They can have worsening respiratory symptoms, respiratory failure. So, for viral pneumonias prior to COVID, maybe someone comes in and we watch them for a day or two. because this disease is so progressive and so concerning and progresses in so many people, we end up keeping them and watching them in the hospital a little bit closer. We're checking more labs than maybe we usually would with typical pneumonias. And so, the step-down floor, it kind of similar to the ICU, is just different in that, we're talking to the patients and we're relaying information, but no one in the hospital, and just kind of changing the dynamic of how things work. What I would say from my perspective for the hospital that I'm at, they did a really good job of preparing for how the hospital is set up. So what they did at Banner, at least, they took our old circular hospital wards, and they put all of the patients that have coronavirus, behind glass doors that you could see. They took all of the machines that you need information from. So they're inside the patient room, but they're facing out. So you can kind of look and you can see everything. They took extension, like IV tubing, stuff like that. They pulled it all outside the room. So that nurses, to change an IV, all they have to do is go change the bag. They don't have to put on all the personal protective equipment and stuff, because so many of the things that the patient needs are outside the room. So we're doing a lot of things that are somewhat innovative, I guess, to try and minimize our PPE use and things like that, which is kind of cool to see. They also have a really robust backup system. So aside from the critical care docs, we also have anesthesiologists who are critical care trained that are kind of like our backup line for, as we get more and more patients, and our ICU and our hospitals getting fuller and fuller with these extended stay and increased number of cases, that we'll have more critical care trained doctors to help take care of them. We also have pulmonologists who are helping manage vents that are being managed, and then the patient care being managed by like a internal medicine, like a hospitalist. So we kind of have this backup system where we can care for more people that are more seriously ill. So I think, from that perspective, it was really cool to see how fast all of those things happened at Banner. Because I was there in, March, April, kind of when all of this really started to hit the fan, at least in New York and somewhat in Arizona. We were a little bit behind them in terms of our total number of cases at that time. Now at the VA, it's kind of interesting because there's, like I said, right now, all of the attending physicians are in the hospital, and the residents aren't actually seeing any of the people who are positive with coronavirus or suspected positive. So they essentially, a lot of these physicians who are normally have a role as like a teacher and work with residents, they're just seeing patients with coronavirus and helping take care of them, so that essentially to protect the residents, if you will.
Well, I'm curious to know, so we saw in Italy and Spain and other places that the system became overwhelmed. It seemed that we were on the brink of that in New York, but it didn't quite happen. What's the situation where you are in terms of capacity and just in terms of stress to the system? I mean, are you guys in Arizona maxed out or borderline beyond max capacity, or was the preparation enough that hard to say that a global pandemic could be categorized as under control? But relatively speaking, do you feel as if the preparations and the planning were adequate thus far?
So what I would say is, for Arizona, we seem to have a little bit more time than some of the other major cities. And some of this planning that we were able to do, I think, helped prepare us. Banner put out a statement saying they were at somewhere around 80% capacity for their hospitals, meaning that we're having a lot of patients. And I think part of it's not, sometimes people see in the news the number of new cases, which is important, right? Because it's telling us what's going to happen in a couple weeks. But what's also important is how long the people have been in the hospital. It's kind of a stacking effect is what we're starting to see. And I think some hospitals in New York felt very overwhelmed during kind of when they were hitting the peak. They peaked, a couple months ago, or it seemed like they peaked a couple months ago. And what we heard from talking with other physicians is that a lot of the hospitals were stretched really thin. I wasn't there. I can't say firsthand experience or anything like that, but just talking to our critical care doctors, some critical care attendings there were, sleeping in the hospital, having to stay, work extra hours, things like that, just to care for the number of sick people they had. Respiratory therapists from our hospital were leaving to take jobs out in New York because they were paying more kind of short-term gigs to help with their need. So I think for a lot of healthcare systems in New York, they probably got stressed pretty hard. In Phoenix, we're heading that way. I think when you talk with the critical care attendings who are doing ICU, 24/7, they're starting to feel the fatigue. They're starting to feel the stress. When I see interviews from my colleagues, it feels like everyone's starting to feel, it's not just something that it happens and, we're all, ready for it. It's just something that each day kind of weighs on you. Having patients who aren't necessarily improving as fast as others might with this illness, it kind of weighs on your spirit some. So it's a fatigue thing as much as anything else. And then in terms of total capacity, everything I've heard, we're okay right now, but there is concern that in the upcoming months that we're going to have a bigger peak than what we've had so far. I'm curious to see. At one point, I think like most states, we canceled all of our elective surgeries to make room for sick patients, keep the extra beds available, which we have the surgeries and stuff going now. It might get to a point where we have to pause those again for a little bit. We're recommending social distancing, but it might be something that we have to go on lockdown again if things get too bad. So none of that stuff would surprise me, just with how sick the number of people that we're seeing are.
Yeah, it's unfortunate that we were all hoping that summer was going to really punch this thing in the head. And that seems to not be happening anywhere close to as much as we all were wishing that it would. And so you mentioned PPE, personal protective equipment.
Mm-hmm.
There's so many phrases that no one even knew what they were, and now they're part of household lexicon, PPE being one of them. And I've visited with other medical professionals in other areas who have expressed to me that the shortages are ongoing, that we are still not adequately supplied in terms of PPE. What's it like on that front in Arizona?
So at Banner, I would say that we never, at no point did I ever feel like we would be out of personal protective equipment. I don't really have the behind the scenes information, but I can tell you what we did and what was working. So kind of like what I was saying earlier, having rooms with most of the medical equipment that could be manipulated outside of the room helps so that you don't have to go in and out of the patient room so much. We had a protocol where we'd reuse N95 masks until they became soiled or started to, if there was concern that they were loose, and then we'd get new ones. So yes, we would reuse them, maybe not perfect recommendations from the manufacturer, but for the most part, I think it's kept most of the residents and physicians safe. For people who are undergoing procedures, we have what are called PAPRs, or kind of like the space suits that you see in movies. If you have ever watched the movie like Pandemic, the space suit that he runs around in, that's a PAPR. So for like procedures and things, we have that equipment. Otherwise, we wear the N95s, we have face shields, we have all of the gowns and gloves, and we haven't been, at our hospital, we haven't really faced a shortage that has been, nothing that's been made aware to any of the residents. So at no point did we ever feel like, hey, you need to stop using your personal protective equipment. And I would say at the VA, the hospital I'm at right now, even though we're not technically taking care of the COVID positive patients, we still wear N95s, and we have an adequate supply and hasn't been an issue at least for the residents. So if those shortages are out there, it's not something that we're hearing about as residents.
What about the testing? I'm hearing that the accuracy on the various tests and the availability of the tests that are more accurate, that those things are still problematic. What have your experiences been there?
Yeah, so that's a good question. So the nasal swab, I have heard it being quoted as anywhere from like 60 to 80%, so not great. If the test is positive, we typically trust it. So it has what we call a good positive predictive value, meaning that if it's positive, and we're getting it because someone has symptoms, it's pretty accurate. If it's negative and they're not having symptoms, normally pretty accurate. If it's negative and someone has like a cough, we might do a second test. So there's a few different tests that are out there right now available for us in Phoenix. At the VA, we have a rapid test, so we get the results back in a couple hours. We have a limited number of the rapid tests, so we kind of use them for the people that we really need to know, like right now. So say someone comes in and they have appendicitis and they need to go to surgery. We do a rapid test to see, if they're positive or negative so that they can go to their emergency procedures, whatever it is. There is a antibody test we do. Typically get it back pretty fast, probably within 24 hours for most people. It's what's called an IgG antibody. So when your body makes these antibodies, it makes IgM antibodies. They show up in the first 5 to 10 days. And then after that period, it makes what are called IgG antibodies. So kind of a little bit later after the course. The IgG test is the one we've been doing. So kind of telling us, did someone have maybe had the virus that has cleared it, or had the virus and had it for probably at least 7 days, probably a little bit longer than that. And if so, those antibodies pop positive. And so we have the blood test, which is the antibody. We can do blood viral, and then the nasal swab. There's an oral swab as well that I've heard it hasn't been as effective. So I think for Banner and for the VA, it's been mostly nasal swab, which I had to get because I was on a floor that had a small outbreak at Banner. So they made me get both the nasal swab and the antibody test.
Nasal swab's no fun.
It's not for fun. Not recommended for pleasure.
Yes, I have not had a test, but my friends who have, particularly the ones with underlying conditions who wanted to just make sure, said it's miserable.
It made both my eyes water. It made my voice scratchy. I hated it. I coughed. I was like, ah.
So tell me what you know about, because I've read, of course, hydrochloroquine, which was touted originally, which the FDA has now sort of officially said, no, this doesn't do any good. And then there's the drug. It's very hard for me to pronounce these things, but the pharmaceutical giant Gilead.
Remdesivir.
Yes. And then a British pharmaceutical giant has recently said that there's some generic steroid.
Dexamethasone, yeah.
What are you hearing about the different ways to treat this disease, and which ones are actually working, which ones are more hype than substance, and that sort of thing?
That's a good question. So when all of this first started, we had patients coming in who would be requesting the hydroxychloroquine. And there was actually a famous case that came to one of the Banner hospitals where a family, unfortunately, father and wife, or husband, wife, whatever it was, overdosed on chloroquine from a fish tank product, essentially just taking the same name of the drug, even though it was a different salt, and they accidentally overdosed, and it made the national news, and someone died from taking chloroquine, which was, obviously that's not recommended, and any products like that you want to stay away from. The hydroxychloroquine had a lot of hype early on that it might be effective. Every study that I've seen that's looked at it so far, not effective, and actually more risks, more mortality with people who do take hydroxychloroquine compared to not taking it at all. I can tell you at kind of what we were doing at Banner at our ICU is we were looking at inflammatory markers more so than we would with any of these other, bacterial viral pneumonias. And when we would start to see, increase in these inflammatory markers, things like they're called ESR, CRP, we would check D-dimers, basically just lab tests that show that someone's inflammatory system is really ramping up. When that would happen, we would start pulling for the steroids, the dexamethasones, and kind of different types of steroids other than just dexamethasone. But the idea being that when someone gets into this really inflammatory state, it can kind of push people from going from a little bit sick, maybe needing a little bit of oxygen, to their body is super inflamed. They get fluid built up in their lungs, something called ARDS, acute respiratory distress syndrome, and then needing intubated. So when we would start to see people kind of heading that way, the inflammatory markers ramping up, we'd give them steroids to try and bring them back down. The evidence for steroids, initially when it came out of China, they were recommending against steroids. I think that, from my personal experience and what we were doing at the hospital, that seemed to be pretty effective. And quelling the inflammatory storm for some of these people, is that steroids work for the right patient at the right time. So, for a person who comes in and they have a little bit of symptoms, I don't think steroids is the right answer. For someone that's kind of getting sicker, heading towards, increasing oxygen demands, heading towards a tube, the steroids help, in my personal experience. So it has to be the right person, has to be at the right time to give them.
What are the current recommendations for people with mild symptoms who are not hospitalized to fight this thing off?
Yeah, absolutely.
Exercise or over-the-counter flu medications, or what's the current recommendations on that topic?
Sure. So I think one of the biggest thing that people should do is they should stay home. So avoid going out as much as possible, self-isolate. If you live with other people, staying in a room, kind of designate it the sick room, if you will. It's okay to take over-the-counter medications. If you're having high fevers, 102, 103, and it's driving you crazy, you're getting sweating and stuff, so okay to take Tylenol. Treating your symptoms with kind of what I consider just homeopathic regimen. So trying to keep up with your hydration, that's water, that's Gatorade, trying to keep up with your diet, eating soups, things like that. If you have sore throat, if you feel like you're starting to have problems breathing, that kind of becomes the time that you say, okay, we need to go to the emergency department. Maybe we need a little bit more care. There are some symptoms that seem to be insidious for coronavirus: loss of smell, loss of taste. If you're experiencing any of those, I would say stay home, give yourself 10 to 14 days, try to stay away from everyone, prevent the spread. So doing things, washing your hands, cleaning everything you touch at home. It's impossible, but doing your best. Wearing masks at all times. If you live with someone else, it's hard, but if you're sick, wearing the mask really helps you from spreading the disease. So those are kind of the big things, and really you're just watching out for the warning symptoms. A lot of people, this is a mild illness. Some people, all they get is a change in smell, change in taste. Some people, obviously, they head the other direction and they need hospital care. I would always I'd spend a little bit of time working on our coronavirus help hotline where we'd answer calls, and I would always tell people, if you're going to go anywhere, call them first and let them know you're coming, so that you know where to go. They know that you're coming in as a person who thinks they have coronavirus, things like that, so that you're not sitting in the waiting room around other people. Or on the other hand, if you're coming in with something not related to coronavirus, you want to call them and say, hey, can I get a mask? Where should I go so that I'm not around other people who are sick? So emergency departments have done a good job of segregating people based on symptoms, but it's always good to let whoever know that you're coming. So even if it's an urgent care, a family med, office, call ahead, tell them you're coming, tell them what your symptoms are. Emergency departments as well too, and they can tell you where to go. So just kind of keeping an eye on your symptoms, watching your breathing, and then having a plan for if things were to go wrong. One of the things that we're doing in the hospital that's kind of unique for this disease is we're doing what's called self-proning, meaning simple as having someone flip over and stay on their belly for a little bit longer during the day than maybe they usually would. Research is still pending on whether this is going to be effective or not, but from my limited experience at the hospital, it seems like the people who self-prone, meaning they lay on their belly for 10 hours, they seem to, especially the people who are kind of right there, they're needing a little bit more oxygen. That self-proning helps. Basically what you're doing is, if you think about the lungs as having a little bit of fluid in them, by flipping over, you kind of create more space for the air to move, for your lung to get oxygen to your blood. So that's one of the unique things we do. I don't think that would probably be a recommendation for a home thing. If you're to the point that you think you're needing proning and stuff, you're probably needing to come into the emergency department.
And your answer to that question reminded me of what should have been my follow-up to several questions ago, when I asked about whether or not the PPE is inadequate supply or not. Mm-hmm. Are doctors and nurses getting ill where you are? How much of a problem is that? Because, of course, it was a huge problem in Italy in particular.
Yeah. So that's an interesting question. With HIPAA, we don't always know who's tested positive. So unless someone comes out and they post it on Facebook, or you're told that there was a big exposure, you don't really know. There was at least one of our fellows tested positive and posted it online, so everyone knew who it was. And then there were several nurses kind of in the same unit that she was working that all got exposed. It was actually a non-COVID floor, meaning that a floor that we didn't have COVID positive patients. So my guess is someone was either one of the nurses or maybe one of the patients who asymptomatic carrier type thing had it expose someone, even though we were wearing masks. Maybe people weren't seeing them with N95s, and a bunch of people got it from this one exposure. So for the most part, the residency, I don't think we've had any positives in the medicine residency, which is 30 plus people. But like I said, it's not 100% I would know unless someone came out and told people.
So it seems like on the COVID floors where the precautions are extreme, not seeing outbreaks, but on the non-COVID floors where maybe someone got infected from their kid or whatever, like in Arizona, youth sports are open, and then that person comes into the non-COVID floor having been exposed and where the precaution measures are less, and that's when the outbreak occurred. Is that correct? I know you can't know for sure, but
yeah, that's kind of how it seems. And it's tough, right? So I'm not sure what the current banner policy is, but like at the VA, everyone is getting a test when they come in to the hospital. So symptoms or no symptoms, everyone's getting antibody tested, which gives us a little bit of, if they just got infected, probably wouldn't show up positive, but it gives us a little bit of information. If it was positive, it gives us a lot. If they have any symptoms, they get double tested. So
does that mean you're getting tested every day as you arrive?
No.
So it's the patients coming in, not the doctors.
Oh yeah, sorry. Every patient coming into the hospital is getting tested, and then every person gets their temperature checked. And we were doing that at Banner too, where everyone gets, if you have a fever, you have to go home, and they check everyone every day, faculty or patients, before they come in.
And so my last question is another kind of open-ended one. Where did we go wrong in terms of preparedness? And what should we do moving forward to correct those errors?
Yeah. So I think the most obvious thing to point to is just a lack of testing early to prevent the spread. A lot of speculation early on was that this would be a mild respiratory disease. Viral pneumonias typically haven't been, for the most part, there are some that are pretty bad, but for the most part, the viral pneumonias we see in the US haven't been typically horrible. This one has been bad. So I think from now on, our country will be a lot more alert whenever a new pathogen pops up. If there is, God forbid, if there's a coronavirus in the future that's worse than this one, I think when there's an outbreak, people will be very ready and very prepared, and we'll be doing everything we can to have testing early. It feels like we might have stuck our head in the sand and pretended like things were okay early on. And that really just, allowed for the virus to spread undetected. So just because you're not testing doesn't mean it's not there. What I think it's interesting. I think a lot of the things we did worked somewhat well. We saw Italy being overwhelmed in their healthcare system, and a lot of states, Arizona included, shut down a lot of businesses. Essential business only, social distancing, all these things, and it feels like we flattened the curve. Our hospital was able to have enough time to come up with these preparedness plans. Get the ventilators that we need in case, increasing capacity happens. All of these things, network with the other hospitals in the area to prepare to help share the burden of coronavirus cases. All of these things took time to set up. It took time to set up the coronavirus ward. Essentially, we have a second ICU now aside from our old one. So I think the social measures that we did, for Arizona at least, really helped. and they'll continue to help in the future. So with the amount of connectivity that we have, I think if something like this were to arise again, we kind of know what to do now. We kind of have the playbook of what not to do and what to do. The not to do is pretend like it's not happening, pretend like it's okay, pretend like it's not that bad. What we will need to do is we'll need to test early, test often, and then get people to stay home quick, which we can do with the amount of technology we have. So that's what I would say
So
about
to
that.
you, it's less of a policy thing and more of an awareness thing, as in the next time Americans won't put their rose tinted glasses on and just sort of pretend that this is not such a big deal. In other words, if we as a nation, not just politicians and media, but the citizenry, if we'd listened to the experts and taken them very seriously right away, that this problem would not be anywhere near the scale that it is. And because this became such a problem, your expectation is that the next time around, politicians, members of the media, and the citizenry more broadly will actually listen, pay attention, and follow the advice of the experts in a much more universal way than we did this time around. Is that a fair summary of
I think that's fair to say, and that as the adage goes, if we don't learn from the past, we're doomed to repeat it. So I think that we'll be ready next time. And I think we're doing a good job moving forward in terms of testing, in terms of listening to whenever we say social distance. I think the next big thing to help slow things down is probably going to be masking for people when they're out. The fact that a lot of people are out and not masking and going to bars and things like that, it's kind of like begging for the virus to spread pretty rapidly. So more to come on that, I guess, depending on the policies and things that each state decides.
Yeah, I'm not leaving the house I go surgical mask and then thick cotton long sleeve t-shirts. I cut the sleeves, I put slits in. So I go surgical mask and then double layer of good cotton over that. And I have not been in a restaurant or bar in months. I did go to a bar yesterday, but I know the owner and we were the only two in there. We were hanging out 12 feet away the entire time.
Yeah.
But just socially, and I know that mental health is not your area of expertise, but human beings need socialization.
For sure.
Definitely had reached the point where Zoom just wasn't cutting it. So for my own mental health, I needed to go sit down at a bar, have a cocktail with a friend, and hang out for a little bit.
Yeah.
And of course, I've said this on many other interviews. The reality is that there are no easy questions and no right answers. And so we're all sort of trying to figure it out and doing the best we can. And I said last question, but one more, and it's on a personal note. How are you doing, man? This is this is you're dealing with extremely sick people. People are dying. I know that you're trained for this. Mm-hmm. Well trained. The doctors have to go to many years of school, followed by many years of, you're not a full doctor. You're an assistant doctor could maybe be the right way to phrase what a resident is. And how are you doing? I mean, this has to be wearing on you just emotionally and psychologically quite a bit.
Yeah, it's draining. I think that for myself, I'm doing okay. We have I think switching, as residents, we get the privilege of going, a month on, a month off, going to different rotations and stuff. So, maybe the drain that I was feeling after a month in the ICU and seeing these sick people who are just taking forever to get better, or, on the other hand, heading the other direction, passing away, it takes a toll over time. And I think being able to get out of there after a month and kind of switch, go to a different unit, work with new physicians, things like that, does a lot of good for the soul. So for me, I'm doing well. The patients that I have now, I really like, which is always nice at the VA. Trying to stay healthy. That's the biggest thing right now. I think it'll get really hard if I start to see colleagues getting sick, things like that. But fortunately, not really happening so far.
Dr. Ryan Willen, your time and your candidness and your thoughtful replies they're all very much appreciated. And thank you very much for joining us. And I expect that we'll probably follow up with you at some point over the next couple of months. So once again, thank you so much.
You're welcome. Have a good one, Coach Pete.